All right, good afternoon, everybody, and welcome back to, I believe, part two for you all, actually going into modular three, however, given that Dr. Luis Zayas presented our material for module one and two last week. So thank you to everybody that is coming back to our presentation today. Today we're looking at, and this is brought to you by the National Hispanic Mental Health Technology and Transfer Center out of the Universidad Centro del Caribe School of Medicine. And we're happy to bring this to you as part of our series, really looking at specific approaches to Latinos and suicide, and even more specifically, representing Dr. Zayas' work in terms of the Clinician's Guide to Suicide Prevention and Treatment. And we think, going forward, I think this is an evolving conversation that we want to make sure and carry and go forward with as we move down the road. So I'm going to go ahead and move forward today. Just as a reminder, today's module 3, risk and protective factors, and we have probably, I don't know, about 25 slides or so. I think the material though that we're going to spend some time talking about today is pretty dense content. So not a lot of slides, but I think the content and hopefully some of the experiences that I've shared today will be insightful for you all, especially those of you that are coming into this sort of work and kind of getting exposed for the first time. Those of you that have come to this work by whatever path brought you to this work. I'll share some of my story as we move forward in this, on how I came to do suicide prevention work, because it's not it's not necessarily something you sign up for and say, I want to be a suicide prevention counselor. That's where I want to spend the bulk of my time. I think we're ready to move forward. I don't believe there's any screening questions. Cindy, if there is, jump in. If not, I'm going to go ahead and move forward. But we want to kind of remind you all, as far as the MHTC Network, not just the Mental Health Technology Transfer Center, but all of the centers under the umbrella of the network. Definitely want to start and continue to use affirming, respectful, and recovery-oriented language with any activities or products that we produce, and really making sure that that comes from an open invitation to individuals that come from many different journeys, their own being a strength, comes from strength-based and hopeful approaches that looks at person first and hopefully free of labels, which we know is somewhat difficult given the language that we have been given and taught. Really does need expansion, right? When we talk about some of the categories, for instance, in the work that we're doing today, looking at individuals that potentially are thinking of suicide or may have taken their life to suicide, and really, what does that language look like also, right? So we'll talk about that. Definitely inclusive and accepting of diverse cultures, genders, perspectives, and experiences. And we hope that all of our actions are respectful, are clear and understandable, and of course come from healing and trauma-informed care responsiveness that reflects in our policies, procedures, and also within, obviously, the individuals that are a part of our team at the Mental Health Technology Transfer Center. This work, again, is really trying to look at opportunities for us to kind of expand the discussion, like I said. And just as a disclaimer, all of this content and material is public domain. It is funded 100% by SAMHSA. So if you do want to use this material or reproduce it, it definitely would be appreciated if you reached out to the National Hispanic Mental Health Technology Transfer Center just to coordinate that effort and really make sure that we're able to support you in that. Sometimes our workshops or seminars you may see online or on YouTube, you may catch just a glimpse of it, and that may be very specific to a specific community or agency. So I think it's always really good to have a conversation with us. We definitely have to know that this work is supported by the grant number referenced here, and I won't go through that long list of numbers and letters there for you. I don't have any conflicts of interest to disclose. I definitely do share some personal stories. However, I don't think at all those are in conflict with any of the content and specific material that we're bringing to you. So I'm hopeful that those will actually augment our time together today. Looking at our time together, just to make sure we're all on the same page, looks like we have till about 12:30, and that includes giving us some times at the end for looking at our chat and seeing if there's any communication that we need to answer. I would love for those of you that are in attendance, and I think we're close to about 80 folks with us right now. I just want to say hello to everybody wherever you are around the country. In chat, if you don't mind, just dropping in there a little hello to everybody and let us know where you're coming from so we can kind of see what that looks like throughout the next few minutes as well. And I want to prepare you. So if there's questions that you may have, please go ahead and throw them in chat, write them down. And if you want to ask those at the end, we'll definitely make sure we have some time for that. But, you know, I think as we have learned Zoom, there's somewhat of a delay in terms of what I say and you actually getting that information. So we definitely don't want to have that delay at the end where you're asking your questions and then you kind of get cut off in that respect. As many of you know, Suicide Prevention Awareness Month in September. We are very proud over the last several years. I think we at the center, including Dr. Zayas and his work, or Dean Zayas, is also expanding his research and really looking at how specifically interventions, but even more down the road, I should say prevention, but more down the road, intervention and treatment. What does that look like more specifically when we're talking about Latinos and Latinas and, again, Latinx population in general? I just want to ask for a moment of silence while we remember those that have taken their life by suicide, and we'll go ahead and do that now. So thank you to all of you again for coming and being a part of this presentation. As I mentioned before, we're also celebrating, in addition to Suicide Prevention Month, Hispanic Heritage Month has started as of yesterday, and we want to make sure that we recognize those efforts of Hispanics in our communities, including our school mental health professionals and personnel. They're a vital link to communities, families, and children. Of course, to all our healthcare workers out there, and to you all who are out there and have been open throughout the pandemic, didn't have time down, but continued your work and your efforts, whether that was telehealth or telebehavioral health. We want to thank you for that, and we value your contribution. And those, again, that are coming to this work from direct work historically and over your career directly related to Hispanics, whether you're from that community or are committed to helping our community, we thank you, and we definitely see you as allies and want to always work from that opportunity of collaboration and that sort of issue. So we want to make sure. I just noticed a message from Cindy. Thank you, Cindy. Submit your info on the questions tab. Sorry for the confusion. I guess there's no open chat box in this forum today, but we will make sure when we get to your questions, I will provide my information to you, hopefully here on the chat as well, and or at the end, so you have my email address and have a way of contacting me as well. So modular overview, I want to get into this. But before I do that, I want to just share a little bit of my background before we get into this content. For those of you that have never attended a training with me, I do multiple trainings for the center. Suicide prevention happens to be one that touches very close to home, in the sense that myself, my wife, my kiddos are survivors of suicide, and I will share that experience in a brief nature with you all as we kind of get through some of the risk and protective factors for today. But that work, again, I never, when I first got into the field 20 years ago, 21 years ago, going into a clinical social work program, did I think that my journey would take me into really working directly with suicide, and not only suicide prevention, but also intervention and treatment. And it was really apparent to me early on, even before our experience with suicide as a family, probably about 8 years ago, at this point, 9 years ago, is that we also, or I also, in my internship at a school, in a school-based health center, had my first experience with Latino clients coming to me and us uncovering that there was suicidal ideation and plans and a lot of other very specific behavior that I'll share with you all in just a little bit. But an overview of the modulars, I think, will help also connect my experience to that. I've been in the field over 20 years now, and it sounds like a really long time, but it's gone very fast. I'm very thankful to be a advisor, technical assistance, content expert, and trainer with the National Hispanic Latino Mental Health Technology and Transfer folks. Previously, the Addiction Technology Transfer Center, and I've been with the center going on, I think right now, 10 years, possibly even 11 years. So I'm very blessed. We have a really good team over at the center, not only of our administrative team and really our coordinators and directors, as well as Cindy, who's organizing this behind the scenes. Thank you, Cindy. Our whole team has really just come together, I think, over the last couple of years, and I'm very blessed to be a part of that. I also am a national trainer for the Matrix, Claire Matrix, now formerly the Matrix Institute on Addictions out of Los Angeles, and they developed the intensive outpatient model, the Matrix model for addictions in intensive outpatient programming. So I do that also nationally and usually train about 20 to 30 agencies around the country every year. And a lot of my work also stems in community development, working as a technical assistance advisor on behalf of the center for local counties here in New Mexico. And then I also do some contract work as an evaluator and consultant for a local DWI program that serves very specific alcohol-related issues and clients that are actually, ironically, in many cases, dealing with suicide, at least ideation or attempts in the past as well. So I tend to stay in my work a lot of times, especially within our state, is very much focused in socioeconomic communities that are usually low access rates for Latinos, really high social disparities and disparities when we look at some of the risks and opportunities for potential harm, not only to themselves, but also to public safety in addition to that. So with that said, I'll share with you more as we go. I hope you guys continue to join us for module 4 and 5, which is coming up in the next few weeks. And then we're toying with adding another, a 6th component, which is actually a self-care module, and I'll continue to talk about that or integrate it in my next few weeks with you all. I'm hopeful that you join us, not only obviously for the duration of today, but over the next couple of weeks. So you all spent some time with Dr. Zayas last week, some tough shoes to fill and follow after his presentation, but I'm hopeful that I can keep us, at least engaged and really open to some of the things that we're hoping to share with you all over the next 3 weeks. So module 1 and 2, introduction of Latinos in the US, kind of looking at the demographic and also looking at related data specific to suicide attempts, lethality, etc. Introducing of suicidal related terms or suicide related terms also was covered last week, I believe. And I may obviously there may be some overlap to a degree with that. But module 3 is really dense in the sense of risk and protective factors when we look at the work that we're here to cover today. And of course, module 4, assessment, prevention, and intervention. Module 5, looking really specifically at schools and how that system really becomes an integral part to connecting youth and families to services in the sense when a suicide may be detected, reported, or obviously in the sense of uncovered in some way, and we'll talk about that as well. So module 3, real important work, looking at risk and protective factors. And with that, I think we definitely have to look at a couple of objectives for our time today that may carry over into next week as well. But it's really looking at identifying risk factors for suicidal behaviors among Latino populations. For the most part, we tend to to a degree, we focus on youth and young adults, but we are seeing increased rates of suicide, ideation, and even attempts with our older population, with our elders. So I think we have to just kind of keep our eye on that as well as we move forward with the content today and into the next couple of weeks. So second bullet here in objective 2, we'll look at the protective factors for suicidal behaviors in Latino communities. And one thing that I want to make clear is that sometimes when we look at risk and protective factors, we may see some overlap between the categories, meaning that there may be risk factors that in some cases may also act as protective factors and vice versa. And I will get more into that as we get to those slides so that you definitely know what I am speaking about. And some of the content I want to really connect to this presentation, because there may be some of you out there that have not taken the cultural elements training that the Mental Health Technology Transfer Center puts out. I think it's really an important training to request from us or look for its availability. You may also find some of it online. However, if you request from us to go out and do a training for your agency or community, we probably can maybe work that out for you. But the last bullet here, address the role of culture and cultural values in relation to risk and protective factors as they pertain to suicidal behaviors. So we really want to make sure that we understand the role of familismo. We understand the role of fatalismo and familismo, as well as respecto. And also when we look at the role of building of trust within this experience as it relates to the therapeutic alliance piece, right? There's things that we have to really look at there as well, where sometimes somebody's distrust for systems and distrust for providers may be a protective factor, in the sense that they have created that because they may have tried to seek help, may have gone to a provider and not been treated culturally appropriate. So again, just one very basic kind of example of sometimes protective and risk factors can be a little tricky, and we want to make sure that you all have a really clear understanding of not solely categorizing risk and protective factors in their respective category, but looking for some fluidity between those two domains is really important as well. So according to APA, American Psychological Association, a risk factor is a clearly defined behavior or constitutional, psychological, environmental, or other characteristic that is associated with an increased possibility or likelihood that a disease or disorder will subsequently develop in an individual. Wow, big definition, right? So let's kind of break this down just a little bit. When we look at constitutional, for example, genetic, we definitely have to think about what does that look like when it comes to mental health disorders and or addiction, specifically in families, whether that is also a part of generational trauma that families have experienced through colonization, through suicide, through other experiences of trauma. Like, for example, another one that we can share is acculturation or assimilation, if we want to use that word, that a lot of times assimilation is usually very violent for individuals that may not want to assimilate into a power or government or entity that they may be forced to be a part of. And that's where we're seeing a lot of issues now rising up on our borders here in the United States, relative to individuals seeking asylum from their home countries because of violence. Other aspects of that we see are the psychological. Now, this presentation, which I think it should, and we'll probably keep amending it and adding to it, but we also have to look at adverse childhood experiences when we're looking at, especially psychological as it connects to environmental. But looking at the psychological domain right now, I think we have to think about What is it specifically that an individual has experienced before they're actually sitting in our office speaking about or reporting about their thoughts about suicide, right? What is the experience, the journey prior to that? And that also plays into some of the work I know Dr. Zayas touched on last week, where we're looking at acculturation gaps. And not only that, but what was the journey like itself for this individual, if that is a part of their experience. This may be an individual that may be in the United States third or fourth generation, but in this case, psychologically, I think we have to look at that. The other aspect of this that I believe we have to look at as it pertains to the United States is, how does racism and discrimination play out, not only in the environment, but then psychologically for individuals. And that's even when we talk about individuals that have been in this country third or fourth generations, or maybe even native to this country, in the sense that their family didn't immigrate from another country, right? But they are born here, they have phenotypical traits and characteristics that would make them look like and resemble people that maybe have immigrated here, maybe from Mexico, maybe from South America, maybe from the Northern Triangle area, right? And maybe even speak the same language, Spanish in some form, right? Or some dialect. So I think we have to really think about that, because we know that ACEs, when an individual has 3 or 4 or more ACEs, given their experience, that they are 100% more likely, 12 times more likely, and if you look at it in a different way, more likely to have suicidal thoughts, ideation, and i.e. possibly attempts. So when we think about that journey of immigration, and even when it gets to the point that maybe a family is in the United States, yet there is some disruption in the family unit, whether mom or dad or grandparents or the kiddos, whoever it was, immigrated first to this country, or vice versa. Maybe the family immigrated and then they sent for the kids. So there's all sorts of different experiences with that acculturation and that journey of immigration. And I think if we don't think about that, we're going to miss the boat, and we're going to miss opportunities to really help people understand where some of these feelings come from when they are not otherwise associated with anything that we can pinpoint when we're looking at mental health disorders with regard to depression and or anxiety, or in some respects post-traumatic stress, in terms of individuals' immigration journeys. We have to think about those individual, especially young people, right, that were removed and stripped away from their parents at these institutions that we want to call family centers, and put kind of a nice title to them, which in many respects they're prisons for immigrants that came into this country or are trying to seek asylum in our country. And we see are going to see, are seeing and are going to see, I should say, the fallout of that traumatic experience for a lot of these young people. And I think that compounded with what we're experiencing now, COVID, and we can't even say post-COVID, because we're still kind of dealing with that, but we're seeing significant increases in the data, specifically around youth that are seeking remedy for their ailments around anxiety, depression, hopelessness, through drugs and alcohol, and potentially by harming themselves and or taking their life by suicide. So we also then have to look at other characteristics that may increase possibilities. Is there something contributing from childhood? Is there other issues going on, whether it's medical and or mental health, disease or disorders that we have to flesh out? So it's really doing a thorough review. And some of the instruments that we've really promoted is the cultural formulation interview, which is a part of the DSM-5. If you look at the back and the appendices, you'll find the cultural formulation interview. Even if you just do a search, a Google search, you'll find it pretty quickly. But that is really a good tool to utilize as you're establishing and doing, in addition to some of the other obviously screening instruments relative to anxiety, depression, other mental health disorders that may be more significant, like psychiatric disorders. So in addition to those, adding the cultural formulation interview, which gives you some of these characteristics that are a little bit more defined and will help you, I believe, as you're working with clients in very specific experiences, as I mentioned, like immigration and experiences with racism and discrimination on top of that, or um, independently of those experiences as well, right? Someone does not have to immigrate to this country to experience racism and discrimination, especially if you have phenotypical traits that look like those of an immigrant. Dark skin, maybe you speak Spanish, maybe Spanish is your first language and you speak broken English, maybe your hair texture, the way that you dress, the way that you interact, the people that you surround yourself with, all those factors contribute, right, to potentially your experience in the United States. And we have to really think about that, especially in today's society where we're seeing racism and discrimination take such a front seat in our social discourse currently. Risk factors that we really want to pull out more specifically. And I think the other thing that I touch on when we talk about risk factors before we kind of go to protective factors, but some people, even when we look at cultural values, like I mentioned, Marianismo, Familismo, Machismo specifically, some people will attach Machismo to the risk factors list, and it very much could be. However, that's when we're looking at machismo through the eyes of somebody maybe taking that cultural value and skewing it slightly by adding violence to that, adding controlling behavior to that. Maybe there's some influence of alcohol or drugs on top of the machismo. But in many respects, machismo can also be a protective factor. Having an individual male figure in a family, especially a Hispanic or Latino family, can very much be something that is a positive thing. When we talk about machismo being an individual male from the Latino or the Latinx population that is hardworking, that is present, is there and around with their family and involved, somebody that is able to control their temper and their violence and their maybe even if they do drink or anything else, that they're able to control that and not allow that to become an additional factor that contributes maybe to the issues that their family is having. So I just want to kind of throw that piece out there as we look at cultural values, because that can also play a role when we're looking at suicide discussion and young Latino males' willingness to talk to individual service providers about their vulnerability, their attempts at suicide, their family history around suicide. So two factors that we have to kind of bring into our discussion today is really looking at the family history of suicide, and really understanding that in many communities, Dr. Zayas talks about this in the manual that he's written as well, that a lot of times the family secrets are what perpetuates this kind of oral history and even vicarious trauma, if you will, within families, generational trauma that we see, where there's unresolved grief and loss, and that family continues to kind of sweep that under the rug, under the carpet, that little Johnny here is suicidal, and we found that he has maybe marks on his arm, maybe from harming himself or burning his arm or something of that nature, and we don't talk about it and we don't openly discuss it as a family. It's not maybe openly shared that Johnny's uncle, his dad's brother, took his life by suicide over 20 years ago, and that there is a history of depression within the family. So looking at this through the lens of a family history of suicide, and even if you do some genome mapping, if you're looking at it through the lens of counseling and social work, can be a really effective tool of just kind of mapping out the family and potentially where in the family there has been any suicides and or depressive like behaviors, disorders, symptoms, etc. We also have to understand that some Latinx communities are also indigenous to our state and our country, right? And with that said, we have to understand that indigenous communities, and when I speak indigenous communities, I'm talking about First Nation people, people that were here in this country before colonization. For instance, in the United States, obviously in this region of where I come from, and I don't think I shared that with you all, but I'm presenting to you all today from Albuquerque, New Mexico. So right in the middle of 18 or 19 pueblos in the Navajo Nation as well to make that 19, we see this very specific approach. And in many families, when we're looking at the Navajo compared to Pueblo Indians in those indigenous communities, many times suicide and grief and death is not spoken about. If not done so very carefully and tactfully, that could be seen as being disrespectful to the family if you're not aware and you're not familiar with the cultural values that need to be preceded before a intake or before any sort of an assessment is completed or even spoken about. And that's where we talk about kind of this kind of platicar and respeto, or communicating, spending some time chatting and talking and having respect for the family in that sense as we go into those conversations. So the other thing that we may have to really think about when we're looking at risk factors are previous attempts. One attempt may beget another, but not necessarily. Usually we do see that there's a progression, and that may or may not, we don't see this in every single case, but it may increase lethality. If the individual attempted to take their life, let's say by taking a medication or an overdose of a medication and or a prescription drug, legal or illegal, we see that sometimes they will increase that risk by maybe changing the substance or their method of lethality. We see that even like Dr. Zayas talked about last week, the violence that usually is a part of a male's attempt or suicidal plan of taking their life by suicide is usually more violent than that we see of a young lady or Latinas. And when I say less violent, I'm talking lethality, meaning that males typically, if they are gonna do the act of taking their life by suicide, they usually use lethal means like a firearm in most cases. Whereas we see young ladies will typically and potentially progress through that, and eventually we see a lot of the outcomes of somebody that actually successfully took their life by suicide, that in many Latinas it's by strangulation or by hanging themselves. So I think we have to definitely think about this. Again, genograms can be definitely something that helps with that helps you kind of put this in a context, looking at the family tree, family history, especially as it relates to depression, suicide, etc. And like I mentioned, the cultural formulation interview, a really good tool as well. And if for some reason you're having trouble finding it, which I do not think you will, please feel free to email me and reach out to me as well. In addition, if you have questions about any of the content that I covered, and for some reason you're not able to pose your question today, please reach out to me and I will be more than willing to share resources and or feedback, and maybe even set up some trainings in your community if that's an opportunity that we may have. So my email address is drjrocky@gmail.com, drjrocky@gmail.com. And I'll say that again at the end if you didn't get a chance to write that down. We also have to look at a risk factor is what is the history in this family relative to grief and loss, unresolved grief and loss, possibly from losing a significant person. We definitely see that attachment issues is prevalent and present in many individuals when we look at the history and the collateral clinical information for individuals that have taken their life by suicide. We definitely see that there may be some history of grief and loss, may be unresolved, and it may be due to losing a significant person in that individual's life, i.e. parent, grandparent. Um, we see a lot of siblings that lose another sibling, and that's traumatic for them. And then we also see, at least in our neck of the woods in New Mexico, we have a significant amount of trauma and death due to um, not only suicidality, but more specifically drugs and or alcohol. However, as many of you know, when we look at the data, it's very hard for us to determine for those individuals that did overdose on drugs and or alcohol and lost their life to that, how many of those were actual suicides um, that were successful in that sense, right? So we won't ever truly know that information in that data. Now, if you look at brain scans, there is significant correlation, even if you're looking at some of the recent like CET stuff with brain damage as it reports to professional football. There's a correlation with that trauma and that damaged part of the brain that correlates with individuals who are experiencing suicidality, and whether it's planning, talk about suicide, and or even attempts at suicide. So keep that in mind when we're talking about individuals that come to you and seek you out. And the other thing that I want to mention, when they do seek you out, think about that it may not be grief and loss because of their losing a human being. It may be because of their journey. It may be because of losing their home country and having to move from their country to the United States. I think it's maybe shocking to some Americans that not every individual that comes to the United States and immigrated here necessarily wanted to do that, right? There may be things in their home country that they still love, that they still want to be connected to and a part of. And that's why we see more acculturation rather than full assimilation, right? Is because people still hold on to things from their home country, cultural values. So that grief and loss may be from that, and it may also be from their experience along their immigration journey. Many individuals that have gone along the immigration journey, whether that's from, again, the Northern Triangle, South America, or Mexico, we see individuals that have experienced and seen a lot of death, murders taking place on the streets, maybe even their own life being threatened to do activity for a gang or for a coyote, somebody that is transporting individuals across the border for a fee or for ransom, and or for human trafficking purposes, right? So grief and loss can be many different things. I just want to be cautious that we don't get so narrowly focused on this that it solely looks like it's the death of a person. It can be these other things that I mentioned as well. Uh, this slide is real specific, and this is based on Dr. Zayas and others' work that really looks at child maltreatment and neglect. And this is again where we see adverse childhood experiences, ACEs, that have a significant impact on the individual and potentially their long-term outcome with regard to mental health, physical health, and even access to services. Right, when we look at those things for young adults or adults that may not get their symptoms or their issues treated as a young person or as a teenager or an adolescent, but they start to see these things impacting their day-to-day activities and functioning, much more specifically in their young adult life, not able to hold down relationships, maybe not able to hold a job, maybe an addiction has taken over a lot of their decision making for them. And then we also then see individuals that are really into the depressive side of things, where they may be experiencing actual suicidal ideation, planning, and maybe even attempts in young adulthood as well. So trauma can place a person at risk for suicide, definitely. And we see that if you just do a search around ACEs relative to suicide, you'll see those numbers skyrocket. Now, I think there definitely has to be more work and connection between the Latinx population and ACEs. I think many of the studies that I've seen from ACEs is really around kind of mainstream populations that we see, not necessarily those that come from other countries, and maybe those that have been discriminated against and or treated oppressively in certain instances. We also know that the accumulation of stress, right? Even when it looks at acculturation stress and immigration stress, that is cumulative in the sense that these stressors can add on to a point where they then are putting this individual that's experiencing those at risk or on the border of having a chronic illness and or mental illness. So suicide can be a result and a symptom of unresolved grief and unresolved treatment, maltreatment, and neglect as well. And I think that's important to know as it relates not only to, again, ACE's work, but also Dr. Zayas and others in their 2005 article. And I'm really hopeful that the center shares the guide with you all once we get that done, which it's really in its final stages of evolution as well. So now we start to think about a little bit in terms of mental health disorders and symptoms. Now, the training that we do around cultural elements, this training doesn't go so much into that, but we talk about issues or mental health disorders as they relate culturally to the Latino population. And that may be coming through bouts of anxiety. It may be coming through loquera or experiences of as explained by individuals, feeling like they're going crazy, right? And we have to think about what does that mean culturally, and what does that mean when it looks at it through the lens of Western medicine. I think we always want to be cautious before we slap on a diagnosis of an individual, work through with them to talk about their assimilation, acculturation, their immigration journey, really do a thorough cultural formulation interview before we kind of go to where there's a diagnosis of a personality, borderline antisocial, major depression, or feelings of hopelessness. Now, not to say that the feelings of hopelessness won't be present. I just ask that before we always throw a diagnosis onto someone, that we ethically do our due diligence to make sure that these aren't just adjustment issues and symptoms of a journey of immigration or acculturation that may be easily resolved through some basic education, access to some basic mental health services and support. And in many respects, I think that's something that we have to think about. A lot of the work that comes out of the ACEs area and authors of ACEs, researchers, talk about the fact that countering some of the basic needs when we look at Maslow's hierarchy of needs can sometimes reverse or counter the long-term effects or potential long-term effects of any of these major disorders that we see. So helping somebody get a better job, helping somebody put food on the table, or find a job that maybe they don't have to work 3 jobs to make the same salary that they're making for 1 job, and that's causing them to be away from their family, and so on and so forth. So sometimes there's some basic low-hanging fruit needs that we can meet, that we can grab and really help with before we go to a full-blown diagnosis and let's treat somebody, or let's think about putting somebody within a residential treatment facility or any of that stuff. However, it's not to say that there aren't individuals that may need that level of intervention and treatment. So I want to definitely make sure that we cover this slide in more detail. So impulsive or aggressive tendencies that result or reflect really a dysregulation or inability to self-regulate may impact suicide attempts, right? And we always have to be aware, as we know, that we are responsible and we have a duty to report and inform if someone's ever going to do harm to themselves or others, and they report that to you. We have a duty to try to stay with them and preserve them and help connect them to safety if we feel that there is potential for danger there. The Columbia scale for suicide assessment is really good. That gives people a really good 2-page screening on the risk, and really puts you in a good position, I think, then to make a decision moving forward as to, do I need to stay with this person until an ambulance comes? Do I need to stay with this person until a loved one comes and takes them to intake that you've arranged and that you are going to do a warm handoff with? So there's many steps as we start to get into content for next week, and I'll kind of leave that there at this point when we start to look at safety planning, and of course making sure that we're doing our due diligence around safety. And I can't stress this enough, folks. Safety is paramount, right? You never want to be out there on an island by yourself and we didn't take the steps, or we didn't inform our supervisor, or we didn't, keep and stay with that person. I'm very fortunate. I've worked with a lot of clients who report suicide and are suicidal actively at the time of me interacting with them. I've never lost a client directly to suicide. However, our team at an agency I started here in Albuquerque has lost a family member that we were engaged with to suicide, and it's never an experience that I would wish on any clinician, any provider, any peer support worker, counselor, anybody at any level of their profession and the work that we do. It's just a hard situation to deal with. So let's do our due diligence, pay attention. And I think when we're at the end of the day, if we're really paying attention and doing that due diligence, people are going to feel welcome when we help them resolve some of their anxieties about seeking treatment. Hopefully that will help. When we help reduce the stigma in our community, as this slide talks about, it will hopefully lead to reduced apprehension and reluctance to seek services. However, as we believe at the center, if you're doing things through a culturally engaged manner, taking into consideration cultural elements, in this case specifically with Latinos or the Latinx population, we know that this may increase the propensity, decrease the propensity to further stay away from seeking services, right? Now, in this case, unresolved stigma and feeling shamed or guilty or any of those things that go with stigma many times definitely may increase propensity to attempt or complete a suicide. So we have to understand that there's things that we can be more aware of explicitly and implicitly as far as what we say and do that will help clients feel more connected, and in many cases will help us resolve some of the stigma. We've had to do this in our community in northern New Mexico, and I'd say it's really awesome to see now. We have many walks of hope. We have many suicide prevention walks that are happening this month and throughout the year, that has really come from the work of local community organizers and service providers to help to put this out there to our communities, that it's okay to seek help. It's okay if you're feeling that loss of somebody deeply, even to a point where you may be considering taking your own life by suicide. We all know, those of us that come to this work by working directly with communities that are of Latin descent, the stigma related to mental health conditions and services is prevalent in our communities. It's alive and it's real. So to ignore this and to make sure, or to not make sure, that we're paying attention to the language that we use in order to promote our services or to recruit clients to come into our services. If we don't pay attention to the language that we use in those, the tone potentially that we use in the way that we communicate, potentially we're going to continue this, I think, incomplete connection, if you will, or lack of connection in some cases of our Latinx community members to treatment that may save their lives, and in many cases may save the lives of people around them, when we're looking at copycat and also kind of this generational trauma related to suicide, that in some families, suicidal attempts may continue. Suicidal thoughts may continue in those families. Acculturative stress, we know that there is, and I know Dr. Zas touched on this. I watched the presentation last week I'll talk a little bit more about this, but really looking at acculturation as something that we can even measure with young Latinos, right? That come from other countries and they immigrate here to this country, whether with their family or an adult caregiver. We know that Latino youth typically acculturate at a much faster pace than do their parents or grandparents' counterparts, because they have access to supercomputers in their pocket. They're on social media, Facebook, Twitter, what are the other, Snapchat, and all these other social media outlets that are out there that put out information. So in terms of the amount of information that someone is experiencing and deciphering through, it can become very stressful and overwhelming to young people. The same for adults and grandparents that are raising grandchildren in some cases, where their young one is acculturating at a much faster rate. That means psychologically and socially as well. And there may be conflicts in the home around communication, around the individual young person's kind of separation in some respects from the family and from maybe cultural values of their home country that are maybe still very strong and important to the parents and grandparents. So these differences in behaviors and information access practices, which it goes into information access and values, may increase levels of conflict. Like I just mentioned, it may increase miscommunication, and it may lead to suicidal attempts and psychological maladjustment. So acculturative stress and minority stress are two that are very much connected, and are things that we really have to think about. Now, when we get into the protective factors, we want to really make sure that we're looking at this a little bit more specifically also, as we start to look at cultural values. And looking at our time, I think we have probably about 15 minutes more or so, maybe 20, and then I will go back and see if there's any questions that we have here at the end. But again, kind of looking at these protective factors, these may aid in decreasing the probability of a disease or disorder. They may help the individual reduce the severity of maybe existing pathology, and they may mitigate some of that stress that's generally contributed to acculturation, as well as we mentioned, the minority stress that individuals report around discrimination, racism, because of their phenotypical traits, the language that they speak, the accent that they carry, etc. Mental health factors, or mental health care, I should say, is one of the protective factors that we can see is very important. Here's a link that we really wanted to share with you, that is a comprehensive approach to social connectedness. And this definitely begins when we look at mental health care, as I mentioned, with a clear assessment of those underlying mental health issues or substance use misuse disorders. However, the cultural formulation interview also will give you this other instrument or tool to help you do a thorough assessment of protective factors that may be helping, which is included here. The connectedness to family, friends, and communities, which are all cultural values and protective factors. There's other interests that they may have and purpose, like spiritual or religious groups, other community groups that may draw their interest, that may be connected to their home country. Maybe it's something connected to work that they've done in those communities, whether it's connected to, like I mentioned, a specific spiritual group or religious group. Definitely look at that. Look at the list here at the website that we provided to you, and I think it'll hopefully give you guys some ideas on kind of what to think about when we're looking at this connectedness. Obviously, other systems that we don't have here that the families, Latino families, can feel connected to and it's not, I'll say it's not too common at this point. So if you do have this in your community and you guys have done a good job in really connecting with Latinos and Latino families, maybe your schools, are really good sites of connectedness for Latino families, and maybe not. I think that many of you may be familiar with the Youth Risk and Resiliency Study or Youth Risk and Resiliency data. And that is data that is taken from schools across the country that participate, and it tracks them through junior high into high school and really gets a sense of all these different kind of risk factors potentially. But we know that through looking at all those risk factors, it may impact our ability to develop protective factors. Some of the things that we see in our region are kids not feeling safe at school. Our kids that are reporting feeling hopeless or not seeing any hope for their future. We see kids that don't have any plans beyond, their high school time. So there's things that we can do to really bump up these protective factors and really help, look at that more in depth and more specifically as well. An additional protective factor is teaching problem solving and life skills, right? We can never thoroughly ward off or teach kids about all the risk factors that they may experience, all the triggers that they may experience over their lifetime. But the more that we can teach them problem solving and life skills, the more ability they have to cope and to adapt to change that they're going to experience even more in the next several years, into the next several decades, as we see the Latino population or Latinx population becoming the minority majority in this country. And we are already seeing that other groups in this country that don't want to see that happen are doing things violently and politically to push back on that. And our young people, unfortunately, are going to experience some of that and are already experiencing, whether that's discrimination, whether that is a push to more assimilation, as opposed to acculturation, right? A blending of maybe their home country values and our values, but people in this country wanting people to completely rid themselves of any cultural values or beliefs that come from any place else other than the United States, which we know definitely will impact people's experience with grief and loss when we're talking about Latinx folks that are pushed to do that. And we're seeing that at these prisoner of war camps or these centers, family centers, where people are stripped from their families. We're seeing that acculturation and even more assimilation happen right in front of us. And we have to be, or we should be, outraged about some of those things and stand up for those that are experiencing this loss. And that means those of you that do not maybe look like myself or look like Latinos, maybe you are Latino and come from this group, but you have lighter skin and you have access to certain influences, certain circles, and certain groups that maybe I may not have access to. And the same for those of you that are not Latinos and come from other groups that have more power and political power in communities. Start to speak up for others that you feel are being treated discriminatory or you feel are being treated racially and kept on the margins of our society. We need you. We have to be collaborative in this, and we have to do things in a way that is not pitting or promoting this us versus them dichotomy that continues to be pushed by our government in many respects, especially in the media. The media does a great job of trying to pit groups of minority status, especially against each other. And that's very clear when we talk about this work relative to suicide prevention as well. Self-esteem, as many of you know, can be another protective factor. Level of confidence, a very basic definition, level of confidence that a person has for her, his abilities and value. And I think those are things that we have to really look at, especially when we start to look at the subgroups or subpopulations of Latinos, right? Where we can't, and we will make the mistake that we've made with other racial groups in the past, where we lump all groups of people together. We have to be cautious about that, right? So subgroups of the Latino or the Latinx population are, what about our LGBTQ populations? What about individuals that are single mothers within our families and within our communities, I should say? What about those individuals that are grandparents raising grandchildren, right? So we have all these different subgroups, and each of them have this need for self-esteem. And I think that through our work and our ability to really promote mental health awareness, access to services, promoting these protective factors like connectedness and really reducing stigma, um, can create, in many respects, meaning and purpose that folks may not have seen in the potential for themselves. I always talk about in courses that I teach at a graduate level that we as at times have to lend our vision of hope to our clients and to people that we come across. If we are coming from that place of hope, strength-based perspective, affirmations, if you're coming from that as a service provider, sometimes we have to lend our vision of hope to individuals until they become hopeful, until they become confident and they identify and find connection for their meaning and purpose in life as well. So self-esteem comes in many different factors, right? As we well know. Religion and spirituality in the Latino culture, we definitely have to know that this can be a protective factor. I wouldn't say we should put it completely in the risk factor, but for some individuals that their family religious beliefs is overbearing and almost to a point of smothering, where, and especially when we're talking about this with the LGBTQ population, um, I think we have to very much be aware that religion and spirituality take a very unique, play a very unique role and take very unique shape specific to the individual and the family. We can't just say that all individuals, it's going to decrease their rates of suicide. It may help, especially if we're taking a holistic approach to this, like involving curanderas or healers, involving healers like religious or spiritual leaders, involving behavioral health practitioners and psychiatrists, if that's the need, psychologists, right? So when we're treating a whole person, religion and spirituality become one aspect of that, and we have to know that in the Latino culture, sometimes traditional families can be overbearing to young Latinos who are acculturating into American society, and I think we just have to be careful about where we position religion and spirituality. Have that conversation. A cultural formulation interview and the ability to have that conversation openly and honestly with your client is something that will help to make it very clear in your diagnosis or assessment that this factor of religion or spirituality is either a very protective element in this individual's life, or potentially it's been used as a risk, or it's been pushed on the individual so much that it's become a risk factor for them. And us being able to communicate that with family in family sessions and in our individual work is definitely something we have to think about. Culture as a protective factor, I think we've kind of touched on this pretty extensively. Definitely can provide beliefs, values, behaviors, and teachings that can be protective. And we know in our neck of the woods in New Mexico, in this region, there's certain dichos or sayings, right, that people will provide to young people about the individuals that they are hanging around with. Or one in particular is, tell me who your friends are and I'll tell you who you are, right? Certain sayings of that nature that are a part of the culture that in many respects can also help young people connect to the fact that their family is trying to protect them. We see protective factors through the religion and spirituality. Again, when we're looking at behaviors, maybe more specific in this definition of, we see grandparents that still traditionally may put the sign of the cross on the forehead of their loved one, and maybe even on you as an adult. I know that my mother-in-law does that to us all the time. She'll bless our forehead and ask for or the bendiga, and really try to bless us on our journey and on our interactions with people. So there's these cultural beliefs that are very much rooted in tradition that sometimes, because of acculturation and assimilation, have put these cultural factors either in risk or protective mode. And I think it's our role in that interaction to help resolve that, especially for young Latinos, adolescents and young adults that we see, going into their late 20s that are still having some areas of confusion and difficulty when it comes to their own identity and their own kind of evolution into adulthood. Culture-related protective factor, I mentioned this earlier, but familismo, family cohesion, acts as a protective factor. It enhances the level of connection. It increases a sense of safety and perceived understanding. However, it also can be a form of miscommunication, or it can be, I should say, an environment. If the family environment and the home environment is one of miscommunication, that can also then be a risk factor, right? So knowing that, however, if we help create familiarism and family and really connection through communication, I think that we can resolve a lot of this, a lot of the risk factors that kind of sometimes pop up when there's miscommunication, there's enmeshment, there is maybe some codependency going on, right? And maybe even comorbidity of other mental health or suicide behaviors or suicide history that we don't know of. So really unpacking that and uncovering that is important. All right, I think we touched on that one. So I think we have just a few more minutes, and then I think we're getting close to wrapping this up. I'm so happy. Thank you all. I think we're close to 100 participants or so that joined us today. Thank you for joining us. Family-related protective factors, the mother-daughter reciprocity, mutuality, that can be a site of really good relation building. I'll speak about this and I'll start to kind of share with you some of our experience. My wife and my daughter, and we came to suicide through the father of my children, my stepchildren, taking his life by suicide. So my stepchildren's father, my wife's ex-husband, took his life by suicide shortly after we had been together, I guess maybe 5 years or so, maybe a little bit longer. And we were in a committed relationship. I don't believe at that point we had been married, but we were, the kids were with us full time, seeing their father on weekends. And I saw this time become very important following the successful suicide, in the reciprocity between my wife and my daughter, and them in some respects grieving a man that they both loved. Right, my wife obviously once loved this individual, and was obviously at a place where they were divorced at that time, but there was obviously a history between the two, and I had to, in a way, and it was part of this kind of, when I look at it through this kind of model that we're talking about with Dr. Zayas and others' work, and really pulling this together, it really looks at it through the lens of even machismo. In my role, I was a father and I was their father figure, and they called me dad, still do. I've raised them since they were 4 and 6 years old. We have 3 kids, 2 twins, a boy and a girl, and then my oldest son is 28. Our twins are 26. But at that time, they were juniors and seniors in high school, and my daughter and my wife kind of had this really tug and pull relationship, almost like I love you to death. It's almost like that kind of attachment disorder stuff, right? I love you, I want you close, but get away from me. And it was interesting because our sons, to some degree, whether they admitted it or not, it felt like there was some blame on my wife because she maybe didn't stay with him and they weren't together. And so there was a lot of baggage that came with this successful, taking of his life by suicide, that also impacted us down the road, not just the immediate impacts, but when we talk about that ripple of grief that goes in the pond, um, me also having to step back as a husband to allow my wife to grieve the loss of her ex-husband, right? And in Latino families, sometimes, not all the time, families are still friends, or there's connection, or there's still dialogue. In this case, it was somewhat stressed. My relationship with my stepchildren's father at that time, but we had developed a respect, and at least we're working together for the betterment of the kids. But these relationships are very unique, and they become very unique, and our ability as clinicians to really identify communication styles, patterns, looking at an eco map and also a family mapping of how does this family communicate, who are aligned with each other and who are not aligned with each other, was really something that I had to step away from because I was in the middle of it and also a clinician. But I was first a dad and a father and a husband in this case. So I had to also kind of step back from that, right? And really try to be neutral and connecting my kids to other providers. My wife also seeking her own support, mental health support and therapy, and then myself also going through this grieving process, right? As much as I didn't see myself as having a very direct relationship with my children's father at that time, there was in the Latino culture a certain amount of respect, and machismo also came into this, right? Where I was wanting to protect my family, but I still had to allow them to be vulnerable and go through this process of grief and loss that they were going to go through. Um, and that took us some time, and I think even now as adults, excuse me, as adults, this took us some time to get through. As a family, it's taken us some time. I don't say at this time things are perfect. We still, our adult son still struggles with addiction, and I think is still coping with that loss. This 9 years later, I think my daughter and our youngest son, the twins, have worked through things and have evolved to more positive coping strategies and mechanisms. But my oldest son and my daughter, our younger daughter, both went through these periods of um, um, stating that they didn't want to live anymore and making comments around taking their life by suicide. And we had to very much learn that in hyperspeed. Like I mentioned to you at the beginning of this presentation, I never saw myself really becoming a clinician or a presenter nationally that talks about suicide openly and really connects directly to this work. But I feel blessed and honored that I have a national platform to be able to do so, to speak about our experiences and to say that not all of our experiences as family have been 100% positive and all protective factors, because we have seen some risk factors pop up like mental health and addiction issues going on, which are still continuing. And I see that in many families. The death and the grief and loss doesn't. It's kind of like if you look at Kubler-Ross's grief and loss, the stages of grief and loss, right? Well, just like many families, ours is the one that looks scribbled on is kind of all over the place, right? We go through these places of being angry and then accepting and kind of moving forward, and then we go back to anger. And I've seen my kids really go through that a lot, and I've had to just be there as an adult parent and try to promote them to do better for themselves health-wise, to try to look at the protective factors that they have in their life and stay connected to family that is still here with them and present. And one thing that my wife always talks about, and it's not her quote, but it's one that's out there. Suicide doesn't end the pain for the person that took their life. It just passes that on to someone else. And many times we see that. And that's not to say that the individual that takes their life by suicide or that is thinking of suicide isn't in a tremendous amount of pain, because we know that they are, right? You have to think to get to the point where you sit with yourself and you're thinking about ending your own life. You have to realize how much time and effort and thought and um, guilt and shame and all these flood of roller coaster of emotions that individual is going through. And that's what we call empathy, right? Being able to, as close as we can without becoming traumatized ourselves, put ourselves in that individual's shoes for just one moment, right? And I think that's something that we have to do with the clients that we serve. Now, those of you that are coming to this training because maybe you've recently experienced this, I hope not not yourself or your family or anybody close to you, but maybe in your community, your school, your agency. We have specific recommendations for just kind of thinking through these things. But think about culture and cultural values. Those definitely should be considered when assessing suicidal risk in Latino adolescents. Acculturation and accumulative stress to include immigration stress, we have to know may play a role in individuals' attempts or thoughts around suicide and suicidal risk in general. The consideration of risk and protective factors or protective risk is part of a more comprehensive evaluation that we'll discuss in the next sessions, and that includes what I hope that I'll be able to share with you guys next time is the cultural formulation interview. I know it's not something that we necessarily go through in this training, but as we start to get into next week and the following, I think it's important that you guys have that and you just kind of know about it a little bit more in depth and detail. And then if there's questions at the end, our last session around that, maybe we can use some time then to discuss that as well. But I want to open it up to questions at this time as well. And as we're going through and opening it up to questions, I'm going to go through the next couple of slides that just shares with you all some information. And then I will stop sharing my screen so you all may see me. I still can't see all of your gorgeous faces out there. But again, thank you for joining us today. And we'll see if there's any questions that will be asked of me. And I'll go through the next couple of slides.
Yes, we do have a couple questions. Let me make sure I pull those out. So this one was made at the beginning, and it asks, what assessment can we use for the cultural formulation interview?
Yeah, that's perfect. So I think in addition to any other screening tools that you have, for mental health, case management needs, whatever that looks like, it's also something to consider is the Columbia scale for suicide assessment. I think the acronym is, I want to say CSSA, but don't quote me on that. But the Columbia scale is something it's accessible. I think they even do a training that you can do. It's a very short training that can be done online, I believe. But that's one that you may attach to a cultural formulation interview. What we did here in McKinley County, we saw, and I came in and they asked me to do some technical assistance and be an evaluator of their program. And one of the first things that I saw was that there was no way for us to, at the moment that somebody relayed to the individual who at that time is a LADAC or an LSAA, an associate's level clinician, that they're suicidal, there was no way in this system at that time to then kind of raise the red flag and say, we need to do a more thorough assessment of safety and risk and lethality at this moment, right? Immediately. In those cases, it's called for, especially if that clinician deems that it may be something that is going to impact someone's immediate safety. We then have to stay on the phone with them and engage with them and lock them into that interview. So the Columbia scale and then attaching the cultural formulation interview to that, I think can be done. The cultural formulation interview may be something that you either do at that immediate time or at your second session. I'm hopeful that you will have with that individual to get further information about the cultural experience that they may have. Thank you, Cindy.
Thank you, Rocky. I'm gonna read a comment that we received and then the next question.
Okay.
So the comment says, I just moved to El Paso from Houston and was disappointed to see the lack of mental health resources and organizations here. I'm hoping there will be a AFSP chapter here in the future. It is such a challenge to change the stigma around mental health. My dad died by suicide, and his sister wanted to tell everyone he died in a car accident. Thankfully, I was able to educate her and convince her of the importance of being honest about suicide loss.
Yeah. Wow, that's a great comment and statement. Thank you for sharing that. I apologize for your loss, and I think that's an important piece that you mentioned, is being open and honest. And we had a legislator here in New Mexico testify recently at a community forum that he went and talked with a local constituent in his community that lost her son by suicide, and he went and asked, is there anything that we can do? Do you want us to pay for the announcement in the paper? Or do you want us to help with services? How can we help? And she basically closed the door in his face and didn't want to do any of that. And he felt very disconnected and grieved to that piece because he realized how much stigma is attached to suicide still. So I think having these continued conversations and being able to openly discuss it is something that we have to do more of. It's hard and it's a hard conversation, but I think if we do so tactfully and we are respectful, and we do it with grace, I'm hopeful that the more we can be open about these experiences and educate people, as you said. Thank you for that statement. Cindy, what about the next question you have?
Yes, the next one says, are there some programs in Spanish that address mental health and its important role in our daily life?
I'm sorry, you kind of broke up there, Cindy. Can you restate that one?
Sorry. Are there
That's
some
okay.
programs in Spanish that address mental health and its important role in our daily life?
The perfect question. Yeah, the great. And it goes back to the second question that I didn't answer fully. So AFSP, I think it would be great, the individual that mentioned there in El Paso, there's not a lot of resources to reach out to the National Latino Behavioral Health Association here in Albuquerque or Santa Fe, and local collaborative, I believe local collaborative 3 is in that area of Las Cruces, and they coordinate and work with a lot of agencies in that community that serve that region. But currently, we're actually working to address and adapt the Talk Saves Lives um, model. It's again Talk Saves Lives, and that's being put out by AFSP. Um, and it's actually going to be adapted to include Latino cultural elements and some of the content that we're sharing today. So keep an eye out for that. That should be coming out, I think, in the next 6 months or so. And you're more than welcome to reach out to me, Dr. J Rocky at gmail.com. Again, DRJROCKY at gmail.com for anybody that wants to follow up with me as well. And sorry, to answer this third question, that curriculum is going to be adapted to be in Spanish as well. Other than that, I don't know of many others that are adapted in Spanish. So, great question and something definitely to look forward to developing.
Yeah, and I also wanted to say, for that question, we usually share whatever resources we find that have Spanish options on our social media. So make sure you follow us because whenever we find resources that are great for providers, we try to share them both in English and Spanish. So next we have another comment and then a question, and I think it's our last question.
Great.
So the comments, I think you were talking about a couple of research, and the person mentioned that most of the research that they have found lumps African American and Latinos together.
Yeah, yeah. Yeah, I was talking, I think I mentioned the adverse childhood experiences research, and that's pretty common in that research as well as lumping, again, if they're looking at people as Afro-Latinos, African Americans, that it's kind of this again attempt, I think, and not a really good one to try to pull these different trends out for the population. So I think those of you that are seeing specific ACEs in your communities that you can start to track and really assess, I would definitely look at those through a different lens around some of the information we're giving you, just as it'll help kind of define the issue more specifically, the disorder, and really kind of look at not only the etiology of the disorder, but also how do we kind of look at that treatment outcome, long term, hopefully.
Thank you, Rocky. And then
Yeah.
the last question says, how would you suggest we work with Latinx families to decrease stigma for mental health services without imposing cultural norms or risking assimilation and acculturation?
Yeah, I think it's using some of the cultural elements I talked about today, respecto or respect, building a foundation of clinical and therapeutic relationship that is, based on trust and honesty and transparency. At the end of the day, Latin families, I think, just want to make sure that whoever they're working with is open and honest and transparent with them. Too often they've been told that their information won't be tracked or they won't be used for this and for that, and then they end up getting hurt again. And I think the more due diligence we can do around building trust, doing what we say, saying what we do, is important. I think the language that we use is extremely important when we talk about recruiting or seeking out individuals. One thing that I've made a recommendation on AFSP's curriculum is that in their curriculum, and this is a training that's done by volunteers to community members, they literally in 1 minute they're saying welcome to the training today, and then they actually get into talking about grief and loss and death the next statement. um, as many of you know, we need to warm up to the Latino population. We need to speak with them. We need to talk with them a little bit. We need to share with them our intent and why we're doing this, why we're even doing the training. So I think really giving people information that's factual about suicide is important. Dispelling any misinformation is extremely important. And then lastly, being there to talk with them and invite them in and ask questions is something that we need to do a better job of, I think, in most Latinx communities.
Thank you, Rocky. I'm going to
All
close
right,
with
thank
this
you.
last comment we received, and then you can go ahead and close and
Okay.
say your final words. So the comment says, it is hard for sure working with Latino kids and their families in behavioral and mental health with the cultural boundaries. I find it easy to relate to the parents as a Latino myself in order to build rapport.
Yeah, absolutely. Well said. Well said. Um, Thank you for that statement. Thank you all for the questions. I think I want to make sure and really invite you back next time. We'll start to get into more of the treatment specific content and approaches, and then look at some of the best practices that we can think about moving forward in our last session. And I also want to look at whether we have a sixth module or not. For module 5, I definitely want to bring in my own content that will include self-care, because one thing that we know, doing this work is exhausting, it's tiresome, and if we don't have support administratively and from our supervisors, clinical supervision wise, we definitely will struggle with this. So seek out that support, seek out training, reach out to us at the center if you need more support and training, and we would be more than willing to do that. And I'm going to go ahead and end there. Thank you, Cindy, so much for your helping, facilitating. Thank you to the Mental Health Technology and Transfer Center, the Universidad Centro de Caribe, and the centers around the country. We'll talk to you all soon, and we'll see you guys next week. Have a great week. Stay safe.